because of COVID and trying to answer some questions around what we could share over a virtual platform, but I think we're good to go. So for you guys that are new to this or interns, this is a chance that we have to not only share some quality information, so patient safety and quality generated information and education, but also provide some cases that have happened in our own hospital that are de-identified to learn from. Okay, so again, just kind of as I mentioned, these are quarterly conferences that we have to discuss AHOs, and hopefully by now most of you guys know what that means. So AHOs are all hands-on report, and also to discuss serious safety event reviews. And just remember, as we go through these, it's really a way to provide not only lessons learned, so if something happens in a specific area of the hospital that you might not be privy to that information, we can kind of spread that throughout the hospital so that we can learn from safety events that we've had, but also to provide a team approach. So this is a little bit harder to do in a virtual setting, but sometimes we'll invite our nursing staff or ancillary staff if we've had cases that affect both of those areas. And really, this is a learning platform, so it's not a blame game, it's not who did what, but it's really to learn from events and to find some solutions to system problems that we're having. And also just to provide your involvement. It's not just to check an ACGME requirement, but also, you know, you guys are our eyes and ears in the hospital. You guys know what's happening a whole lot more sometimes than we do after hours. And so it's to generate your involvement in our occurrence reporting and also participate in potential serious safety events that we might need you to participate in. And then lastly, we're going to be talking about the very end. Some residents have more inpatient quality improvement projects. So this is a time that we give for those residents to kind of share what their projects might be or updates on their projects so that we can learn about those as well. So really our education time today is going to be focused on learning what all the acronyms are, because in general in hospital settings, but especially in the patient safety world and quality world, there are lots of acronyms that are not intuitive. And so as we talk about these things, I want you to know what we're talking about. So first, AHO. So this is our all hands-on report, what we call. These are our safety event reports or occurrence reports. If you've been at other hospital systems, they're called other things. The icon to the right is what you will see on your Prisma Health desktop. So this icon is on all desktop computers, and it gives ready access for occurrence reporting. So what is an occurrence report? So really the purpose, and this is really important to understand, it's not punitive, it's purely educational. So just like I said earlier, frontline staff, our residents, our providers, our nursing staff, our ancillary staff, our EVS staff, you guys are our eyes and ears of what a lot of times leadership cannot see. And so really it's for you guys to put in reports around something that just doesn't feel right, doesn't seem right. It seems like it could have hurt someone, even if it didn't or truly did hurt a patient or a staff member, so that we can monitor trends and provide solutions within the system to prevent these from happening. They are not punitive, so people do not get in trouble from occurrence reporting unless something egregious was noted, but people do not get reported for those things. There's a separate, when you do put in, just to let you guys know, when you do put in maybe an issue regard to professionalism, that goes through this same icon, but it goes to a different department. So those of us that see event reporting to find solutions from a patient safety perspective do not see the professionalism ones. They go to a different department. They go to professional practice. So hopefully you guys will understand that and know that that's a separate thing. We also do this to monitor trends. So if we have something going on in Children's Hospital that we've seen and the manager of a pharmacy is able to say, oh, that happened in the adult hospital because of something I saw on a different occurrence report, we're able to really pull those things together and find solutions to prevent these throughout the system. And that gets to the next point, is most of the things that we have, safety events that we have within our hospital systems, are not a result of a human error. They're a reflection of something that's gone on in the system that's not given us a safety net. So when do you do these? So I attached some handouts that Whitney sent along, and you can kind of use these as a guide of when to do an AHO. But really, if you see or hear something that just doesn't feel right, it's never wrong to put an occurrence report in for it. It's never a wrong thing to do. So the only wrong thing would be is to hesitate on doing it. So definitely put in an occurrence report. We will be having some new flyers come out soon around some modifications that is being done to the occurrence reporting system that should make it easier and a little more streamlined for you guys to report certain things. And I'll definitely get you guys a copy of that as soon as those are released. How do you do this? Personally, I think the easiest way is to go through the icon. You can definitely go try to navigate MyPal, which is a little bit confusing, but just going to the icon on the desktop of the Prism Health computers is the easiest way to do that. Or you can call the hotline itself. So when you do the occurrence report through the icon, it automatically generates the report to the people that get it. If you call, even though some people prefer to call on the hotline, it's totally fine to do that, but realize there's a delay. So a transcriptionist has to put that in. So there is some delay in how quickly that we get those occurrence reports through the telephone. What to include? So really the reporting tool guides you through this. So we'll have certain things on there that are required fields, like the patient name, medical record number if a patient was involved. If there was a medication involved, it's going to give you a whole lots of different drop downs that you need to pick from in order to really weed through the details of that. It'll ask you for the campus, so you would pick Palmetto Richland. You would pick whatever unit. So the way they have it in there is adolescents or infant and toddlers. They have PICU, they have CBD. So those are how the units are in there if it happened in one of the units. Or you can pick an outpatient setting if something were to happen in the outpatient world. It's really important to give the details, so including the date and time, that's a required field as well. But very specific events related to what your experience was with the occurrence. And then your name. So this is an optional thing. Some people choose not to put their name in. I would encourage you to put your name in, because that's the only way that any of us can give feedback to the reporter. If you want to know what happens, so once the occurrence report happens, the managers that are assigned to that unit, as well as whatever else it involved, whoever else was tied in as a consultant, have a short period of time to generate feedback and close out the case. So if you want feedback regarding that, it's helpful to put your name in so that we can provide some feedback. And also it's helpful if we have more questions about the event, we know who to reach out to. And then just as a shameless plug, if you really just want a carrot to be thrown at you, know that this is part of your house points. So if you, I track these and give these to the house group leaders, and you get points for AHA reporting, so you'll benefit your team. So who can put in an AHO? Anyone can put in an AHO. So it doesn't matter who you are, what you do, what your specific job is within the hospital. Anyone can put in an occurrence report. And honestly, the more the AHOs on the same incident, the better. So if you hear a nurse saying, if you were involved with something within a nurse and the nurse says, I'm going to put an AHO for that, you say, great, I'm also going to put one in as well, because different perspectives are important when we're looking at how to find solutions to what the problem might be. And then we've already kind of talked about the why behind it, but really it's to monitor trends, so system failures, to provide feedback, and ultimately to prevent harm. There are some changes going forward. I'd mentioned some of the changes with the event reporting tool. So some of them will actually make the form look a little bit different, but also we're going to be changing the name. So just as anything else with the merger and Prisma Health, we're standardizing things. And so they've come up with a new name for the occurrence reports, which I think is a really good name. It's going to be Safety First. And so as soon as that is released, the icon will change, and I will let you know what that looks like so you know how to find it on your desktops. This is just a little figure. If any of you guys have been a part of any kind of patient safety or quality work, you'll recognize the figure down to the bottom right. And this is just the Swiss cheese model. So basically the concept is that there's not one hole within the system that leads to an error that affects a patient. There's often multiple holes within the system. So if an if a harm occurs and reaches a patient, it's usually due to multiple holes within the system that have failed to protect that patient. So within most hospital systems, ours is no different. There are multiple layers of safety nets and protection worked in so that harm does not reach the patient. And that can be, when we're talking about medication errors, that can be safety nets built within the EMR. It can be safety nets within the actual process of giving a medication, safety nets within our own pharmacy, safety nets within the ordering system to protect us as providers from preventing mistakes. So realize that it's not just one person or one thing that usually causes harm to reach a patient. I'm not going to go through these in detail, but this just kind of gives you an idea of what types of failures can lead to patient harm. So it could be a structure issue. It could be within the entire leadership mission of the hospital. So if that's not built correctly, then we won't be able to protect our patients. Culture is a big thing. So this is how we feel about each other. How comfortable do we feel raising our hands and saying, stop, I don't feel right about this. Let's not move on until this is corrected. And how well we collaborate with each other. Processes are a big thing as we've built things within our system to kind of flow over to Epic. This has become a big thing we focused on, and how our workflow is, what our handoffs are going to look like, things that we have within our processes that might be missing to prevent patient harm. Policies and protocols. So this oftentimes you feel a little bit excluded from, but there's a whole system within our hospital that monitor guidelines and regulations. And a lot of these are built off of government regulated policies, that type of thing, but also just on best practice in general around how we should practice within the system. And a lot of times our nurses more or less lean on these policies, but there's also policies that we use as providers and protocols that we have to guide us to make best decisions for our patients. And then technology and environment. We know that our EMR is not perfect. We're excited, even though Epic's going to be a big step, we're excited for some of the changes coming our way with that as far as improvement in patient safety and quality of practice. But also this goes to workspaces in general. So how well your workspace prevents distraction, or has the right lighting, or has a comfortable chair to sit in, or doesn't have a lot of noise and alarms going off. Here are some of the individual failure modes. And so not necessarily how you as an individual, but even how the system can help prevent individual failure modes. So competency, knowing that you have the skills and the knowledge and the education to be able to perform your job. Consciousness, so are you rushed and preoccupied and distracted? And a lot of times that's the system can do a lot to help prevent those things for you. Do you feel fatigued, and do you have bad habits? Communication. So a lot of times miscommunication is not because we mean to do that, but a lot of times we assume things or misinterpret things. critical thinking. This is a big thing, especially for us as providers. A lot of times we'll kind of lock into a diagnosis or get kind of in the mode of, I've done this before, I don't need to recheck myself. But making sure we have situational awareness, making sure we don't have diagnostic bias, we're not locked into something to potentially go down the wrong road for our patients. And then compliance, making sure that we are following the protocols and the guidelines because we know they're there as a safety net. So not being overconfident, not taking shortcuts. So that's kind of what, when we look at patient harm and occurrence reports, those are the things that we're trying to look into, classifying which mode it might go into, which failure mode, and being able to find solutions to prevent those things from happening. Do you guys have any questions about AHOs or how to make an occurrence report? I'm going to take the silence as a no, so I'll move on to the next one. So the next acronym that we'll talk about is SHE. So this is what we classify as serious harm events, and they are any event that causes harm to a patient. So whether you have deviated or not from best practice, it doesn't matter. Any harm that happens to a patient is called a serious harm event. And we investigate these within our hospital system. Most of our work around serious harm events is an affiliation with our membership to Solutions for Patient Safety, which is another acronym called SPS. And this is a national patient safety quality collaborative. Includes about 130 plus children's hospital within the US and Canada. And we all work together to have best practice bundles in place and have systems in place to do our best to prevent patient harm. The different harm teams that are listed are the harm teams that we have here. And like I said, most of these are through our collaboration with our SPS project or membership. So we have central line infections that are specific to our HEMOC patients, which are handled a little bit different. We had catheter-associated UTIs, ventilator-associated pneumonias, and ventilator-associated events, venous thromboembolic events. We have peripheral IV infiltrates and extravasations, unplanned extubations, our falls. So this is one throughout the whole hospital system we track, but we also do this within Children's Hospital. Pressure injuries, and these can be either turning related or device related injuries. We have our adverse drug events team and our antimicrobial stewardship team. So our adverse drug events is all medication events, and then our antimicrobial stewardship really focuses on hospital-acquired C. diff, hospital-acquired MRSA, and hospital-acquired VRE. We have our surgical site infection team that focus mostly on our neuroshunt infections and our spinal fusion cases. We have readmissions, so we follow this within the hospital as a whole, but actually within SPS, this was dropped this year because it's not, after a lot of research, is really not shown to be a preventable harm within children's hospitals. But we've decided to keep our discharge bundle in place because it's worked well for us locally. Our newest team is our nephrotoxic acute kidney injury team. So this team focuses on medications and contrast agents and different things that we order for our patients that might cause them to have a kidney injury. And then our employee safety events. So not only do we follow harms within our patients, but we also follow staff harms. So this could be a slip, trip, or fall with one of our staff members. It could be an injury from lifting. It could be a patient behavioral event where one of our staff members is harmed because of a patient acting out, which we definitely have those within Children's Hospital. And then one that's not on here, and it's not related to SPS, but is also a team that's there to prevent harm, is our pediatric sepsis team. So how do we evaluate harms that happen? So a lot of these, fortunately, we're able to either catch wind of or get a lot of events that we end up evaluating through our occurrence reporting system. So that's why that's so important. So when we have harm identified on a patient, we go to the unit that the harm happened on, and the nurse manager will perform what's called a SWAT. So this is just getting together a chart review of the patient, and depending on what happened to the patient, that's who will be involved in the SWAT. So it's usually the attending provider that was on, if it was related to something on the provider side, the bedside nurse, the nurse manager. Sometimes our infection preventionist will be there if it's an infection-related harm. It just kind of depends on who is involved. And we'll really dig into the case and go through the different potential reasons that the harm could have happened. Another way that we do this within our hospital system is called HEP meetings. So this happens at our campus level. It's called Harm Elimination Team. And we will take what we learned from our SWATs, and we will be invited to present in front of our hospital leadership on what happened, what our lessons learned are, and what action plans we have to put in place prevention. This is also a really good opportunity for us to put forth any barriers that we have in making those action plans happen. And so it's a way for us to speak to our hospital leadership about things that we might need in order to put things in place, or issues that we might be having that are kind of beyond our reach. And then we also have certain methods of prevention and surveillance of harm. So K cards, if you guys have never been up in our nursing break rooms on CBD, it's a little more evident of where these things are, but in our units, they're in our nursing break rooms, and that they're K card boards. And so we have so many K cards on each unit, and that's to really just directly observe process and make sure that we're following our best practice bundles. Our teams also meet, and so before COVID, pre-COVID, we used to meet as individual teams. Some of our teams are still meeting individual if we're working on active projects, but otherwise we're rolling our team meetings into a monthly big hack team meeting that we're doing virtually over Teams. Also, some people can be in person depending on the number. So if you guys ever have time, I know your time is limited, but if you ever have a break at lunchtime on the third Tuesday of the month, that's when our hack team meetings happen. And then we collaborate with other children's hospitals. So fortunately with SPS, we're able to learn from each other. We're able to get procedures and policies and processes from other children's hospitals that we know are performing well. And then they'll reach out to us for things as well. So we're able to share things throughout our membership. And then the last kind of acronym we'll talk about today before we dig into the cases are SSEs. So these are serious safety events. And the difference between an SSE and an SHE are serious safety events that are patient harm events that occur because of a deviation from expected practice. So the definition is a variation from expected practice followed by death, severe permanent harm, moderate permanent harm, or significant temporary harm. So when we classify these, and this is something that our risk management team and patient safety specialists help us with, when there's an event that's noted and we know that there's deviation from best practice, they'll help us classify this using what's called HPI methodology into certain levels. So a level one SSE is death, and then all the way down to a level five, which is no harm, but it almost happened, or it was a near miss, a precursor event. Within our hospital system as a whole, our patient safety specialists monitor and present on levels 1 through 3, but within our children's hospital, we take all of these events seriously, and we investigate all of these through what's something that's called an RCA, or root cause analysis. So like I just mentioned, these are evaluated through root cause analysis. And who is involved in that process? So oftentimes, some of you guys might be invited to attend a root cause meeting if an event happened to one of our patients, and you happen to be taking care of that patient. And so when we do evaluations of serious safety events, we'll do these in what's called a 3-meeting type of method. So our first meeting will be a lot of data gathering. It'll be individual interviews from our patient safety specialist. Oftentimes I will get notified in advance when they're going to be interviewing people. And if you guys are involved, I will reach out to you, or I'll let Dr. Stevenson or Dr. Carney know, or Dr. Edwards or Dr. Gray know that you're going to be interviewed. That way we can kind of walk you through the process of what that looks like, or even be there with you if you feel like you need an extra hand or support. But realize that these interviews are not interrogations. It's not a litigation event. It's nothing like that. It's really just to get your idea on what happened and get your eyes and your ears and share that information so we can find a solution to prevent it from happening again. And so those are the first meetings. And then once we kind of gather all the information from the interviews, we'll pull together a big action planning session to identify some areas and deviation, and maybe some of the system failures that were in place that led that to happen. And we'll develop our action plan. And then our last meeting is, once we have action plans together, we actually present this to our children's hospital leadership, so that they can own those action plans and help us to be able to carry those out. And really the purpose of reviewing these is so that we can eventually manage by prediction, right? We want to be able to prevent all these things from happening. And if we can review them when they do happen, hopefully we will not be reactionary all the time. We'll actually be on the preventative side. So there are order sets specifically for pediatrics, and these are just a few to help guide you, and that's why these are there. So most of the order sets that we have within the Cerner system, and then we have a whole lot more within Epic that we've built, are really there to help guide you. They're not to help you say this is what you have to do for your patient, but it's really based on guidelines, based on best practice. Generally 95% of your patients that meet that diagnosis or meet that whatever are going to fall within the guideline. There are going to be some one-offs, there are going to be some exceptions to the rule, but most of the time the patients will follow the guideline, and these are really to help guide you, to let you know what is considered best practice or what might be a potential clinical practice guideline around a certain area. All right, before we move into our cases, does anyone have any questions about what we've talked about so far? Okay, well, I'm going to be quiet for a little bit, and April or Christina, either one of you two want to get us started with our cases?
Yes, so this is April, and we'll start with the first case. Can y'all hear me? Can you hear me, Dr. Blackburn?
Yep.
Okay, perfect. So we're going to do fever, diarrhea, and dehydration in an infant. So the HPI, as you can see, this is a 7-week-old with fever and dehydration for about 1 day. Mom reported decreased PO intake as well. No other symptoms or thick contacts. This baby was born full term by emergent C-section for failure to progress and non-reassuring fetal heart tones, and had no NICU stay. And they did get their Hep B at birth. So the hospital course, the patient had a temp of 102 upon arrival to the ED. They did just initial workup, just like a CBC, CMP, and inflammatory markers, and those were all reassuring. So they believed her fever was due more to a viral illness, and so they admitted her for more supportive care and rehydration. So our plan was to be started on maintenance IV fluids and allow PO as tolerated. So the system issue was, as you see below, the patient's weight was 4.7 kilos, and they were started on maintenance IV fluids of D5 normal saline, but they were at 45 mLs per hour. This was approximately 2.5 times more than their maintenance rate. Fortunately, an experienced nurse on the 3rd floor caught this mistake, and they discussed this with the resident just to figure out, what their rate should actually be. And it was subsequently corrected to 18 milliliters per hour, which would be her maintenance. Go to the next slide. Okay, so the learning points from this, obviously double checking our orders. A lot of times we do maintenance IV fluids every single day, and we know the formula 421 rule like the back of our hand for most of us, and we don't really check back and make sure that we didn't mistakenly put the wrong order. Sometimes we're admitting multiple patients at a time and putting them on maintenance IV fluids, so you might switch up who you're actually charting under. So it's important to double check those orders once they're all in. Of course, if this was an intern, senior residents should always double check the intern's orders, just adding that extra layer of adding to that checking, preventing harm to patients. So always double check the intern's orders, even as simple as maintenance IV fluids and basic calculations. Under this point, obviously the patient did not get the 45 mLs per hour because the nurse recognized that this was wrong, but newer nurses may not have caught this mistake. So it's really important for us to do our part in making sure that we double check our orders. I've actually been in a situation like this where I initially put the wrong order in, and pharmacy actually has called me and said, hey, are you sure you want to do this for maintenance? So as maintenance. And so I think it's important to note that nursing and pharmacy actually do look at our orders as well. But again, we should create balances, checks and balances to prevent this from happening on our end.
Does anyone have any ideas or comments that you want to make on this particular case? Remember, this is your way of being able to participate. So
Well, Megan wants to say something.
go ahead.
One of the okay. One of the other things to keep in mind is like something that is easy to switch up is boluses versus maintenance. So like with this one, that's what I was wondering if it happened initially, which it wasn't quite, but like they got 45 mLs an hour and they're 4.7 kgs. So like if you had someone, you're like, oh, I'm going to order a bolus at this amount, make sure that you're ordering a bolus as bolus and a maintenance as maintenance.
And that's a good suggestion. And especially when you're ordering boluses, you know, talking with your nursing staff just to make sure they understand that. Because if you ordered that and you didn't tell them you were ordering a bolus, they might have also, you know, called to question that as well. When we actually looked at this case, the pharmacist, who was actually an experienced pharmacist, who confirmed this. So just know that there are lots of safety nets, but it you know, went all the way to nursing, and nursing stopped it on this one. The pharmacist had gotten a ton of orders at the same time and got distracted and just kind of blew through it. So just know that we all have moments, even if you're experienced or not experienced, where you might be distracted or caught up in something else and blow through things and not really double check what might be happening. So fortunately, our nurses caught this one. Does anyone else have any comments?
Dr. Blackburn?
Yeah.
I would just say to that too, that remember that on the flip side, because I've had pharmacy send me orders back that they thought like I meant something else than I did. And so they changed the order. And like it was like the attending wanted a specific dose of an antibiotic and they sent it back to me and I just approved it. So always make sure you look at like what pharmacy is sending back to you. Don't always assume that it's right because it's coming from pharmacy.
Exactly. Yeah. So I agree with that, Liz. You know, always double check what you're signing off on, because at the end of the day, when you click that sign button, it's, you know, you're making that decision for your patient. So make sure you know what you're signing before you sign it off, even if it's someone with more experience than you that sent it into your inbox for signature. You know, everyone can make mistakes. So
I think
Yeah, it looks like we've got a comment. It looks like it says, make sure you ensure the correct units, pounds versus kilograms, and also double check that you have the right patient. So that's important. Always make sure you have the right patient. Fortunately, we do have some safety measures around pounds and kilograms, and in EPIC, it's going to be we have even more safety features around that should help prevent those things from happening. On all of our units and in our pediatric ED now, we have all of the scales defaulted to kilograms and locked in that unit, so that hopefully it will prevent someone from accidentally putting in pounds. But in EPIC and the EMR, there's actually a measure if you've got, I think it's if you've under or over 15% of the previous weight, it'll actually pop up a stop sign and said, is this the right weight for your patient? So even more of a safety net to prevent those pounds to kilogram errors. All right, we will go on to the next one.
Okay, so this is a 14-year-old African-American male with sickle cell and asthma. He was admitted for a sickle cell crisis and acute chest, but he didn't have any fever upon admission, so I remember that. The patient was placed on pain control with morphine, Toradol, and MS Contin, and he was also on his IV antibiotics with azithro and Rocephin. On hospital day 2, he developed this new fever of 102, and this created a SIRS alert due to his fever, tachycardia, and immunocompromised state. The house officer was paged in order to have the huddle. And of course, we know as the house officer, they have to get the senior resident. So they stated that they would contact their senior resident and come for the huddle. The team did not come in a timely fashion, and the HEMONC or the house officer was paged again and no answer. The huddle actually ended up happening 3 hours after the initial call. And at that point, blood cultures were obtained, and it was noted that no update note was inputted. So the learning points for this is obviously we remember the golden hour, and that's why we have started with the sepsis alerts to actually get within that golden hour to change our course of treatment if necessary. So if interventions need to be made, then they are most successful within this hour of deterioration. Sepsis huddles need to occur at the time of notification. So as soon as you get the sepsis huddle, it is important to go down and assess the patient with the nurse and decide on the next plan of action. Of course, answering pages in a timely fashion is important as well. In this case, it was kind of limited on the senior resident responding as well. So if a senior has to be is actually busy, which I assume in this case, they probably were appropriately busy, whether it be like they're in a PUI room and they can't come right away, or they are handling another deteriorating patient, the intern themselves can at least go down and assess the patient with the nurse. So if like a quick plan of action needs to happen right then, there is a physician right there and ready while waiting for the senior to arrive. Any add-ons to that?
I will do a quick add-on as other people are thinking about what they might want to say. You know, I want to remind you guys too that if you day or nighttime, especially at nighttime when we're physically not present, this is a great time to call your attending. So if you as the intern can't get hold of your senior, if they're busy and can't come with you, call us on the phone and go assess the patient, and we'll do that over the phone. You can bring the robot with you. We'll do that with you. So don't forget that we are available to have those conversations with if your senior's not available. Does anyone have any questions about sepsis huddles or concerns or issues that they've had with them?
I think also if there was I think any sepsis huddle, obviously we need an update note, but it's especially important when we're changing or adding on to their plan to include that update note so there's no miscommunication in the morning if it's overnight or whatever, so the next team can understand what happened. Gabrielle's going to add something.
Okay.
I know like sometimes it can seem like it's just a lot going on all at once, and with the sepsis huddles, it can just be like another thing to do. But last year we actually had a patient pass away like 30 minutes after a sepsis huddle. So these are to be taken, you know, not lightly.
That's
And I
right,
think
Gabrielle.
sometimes it can be a little annoying getting like the same patient and you just kind of roll your eyes at it. But I think it's important to note that it's kind of put in place for us to reevaluate those patients who are sick over and over, because things can really change pretty quickly.
Yeah, I agree with that. I think another thing that's important for you guys to understand, because a lot of times you don't get feedback from these things, but as we've had the sepsis huddle or the sepsis alert in place, when we see the huddles going successfully and interventions being made, as we've had a lot, you know, that's definitely improving and increasing. And in this last block and the last 2 blocks, really, you guys have done a wonderful job of huddling and making interventions when necessary. I've seen a whole lot less transfers to the ICU in the middle of the night. And I really do think it's because we're seeing patients that might be earlier in the deterioration process and making interventions on them and making changes before we have to go down that process. So it definitely works when it's done correctly. And you guys have been doing a great job in the last couple blocks of that.
Just real quickly distinguish, like differentiate what needs to happen at a like Sears alert versus a sepsis alert.
Yeah. So right now, the way our Cerner predictive analytic tool works is it will fire either a SIRS alert, a sepsis alert, or a severe sepsis alert. So when that alert fires, if it's a SIRS alert, then the nurse will act on that, and they will fill out what's called a screening form. So they will screen for high-risk conditions or high-risk clinical findings that might escalate that to a sepsis. So if it's a high-risk SIRS, or if it's a sepsis, or if it's a severe sepsis alert, all 3 of those situations will require a huddle. So during the huddle, the nurse can bring up the alert and show you what has triggered on your patient. You can also go through the flow under where you see results review and everything. If you pop down to early warning alerts, you can actually click on those alerts, right click on what alerted, and it will show you what triggered the alert to happen. So it could be a combination of vital signs plus a fever plus maybe some lab abnormalities, or even an assessment like a cap refill or a mental status assessment that triggered those things. So if a nurse is calling you for a huddle, that means they've already screened them. If they're SIRS, they've already screened them for high-risk findings and they're high risk, or they've triggered the sepsis or the severe sepsis. So those huddles are really for you guys to communicate with your nursing staff, reevaluate your patient, and decide if intervention needs to be made on your patient. Does that help at all?
Yeah, thank you.
Any other questions? Okay, we'll go to the next one.
Okay. So this is a 14-year-old African-American female with history of sickle cell, asthma, and dysmenorrhea who was admitted for vaso-occlusive crisis. She was placed on a dilated PCA with continuous infusion and scheduled Toradol. On hospital day 10, the decision was made to start oxycodone, 10 milligrams Q6, and discontinue the continuous dilated infusion, but keep the PCA demand dose. So those of us who have done HEMOC know that that happens quite often. The system issue was that the resident wrote in the PCA order to discontinue the continuous, but it was still continued, and the oxycodone was also administered at the same time. So the learning points from this, and pretty much every AHO, is discuss changes with the plan face-to-face, or at least over the phone with the nurse. I can't tell you how many times I've caught a mistake that I've done just by talking with the nurse, trying to go through like what my plan of care is. And I'm like, oops, I didn't mean to say that or do that. So just going that's just an extra check and balance too, and then making sure there's no miscommunication between the nurse and the resident. For this particular case in general, you can also place a nursing communication order because the PCA, everybody knows like the PCA order, you have to have, keep it there in order to continue the actual PCA itself, even if you want to discontinue the continuous infusion, if that makes sense. So you can't actually cancel the whole order. So that being said, you can add an extra order just to make sure that that is communicated and cover all the bases, and actually put in discontinue continuous infusion at this time in this case, so that the nurse will actually see that, because they really do look at those communication orders all the time. And then also within the PCA order itself, you can also change the rate of the infusion. I'm not sure if this was actually done. I forgot to look for that, but in general, just make sure you change it to 0 milligrams per hour. So then they always see those updates for the PCA, because especially the HEMONC nurses, they know that we're changing stuff every day with our sickle cell patients. So they'll look at those orders and see if any changes have been made. So if you put 0 milligrams per hour, they'll see that you discontinued it as well. But I think the biggest thing from this is just discussing those changes, because it's easy to miss those things in the computer that have been those little changes that are made.
I think also it's important to know that what you see in the computer and what our nursing staff sees in the computer look very different, which is sometimes hard to understand. So when we put in special comments on our medication orders, those things are not face up for the nursing staff. They have to hover over that order and see if there's a comment, and oftentimes that's just not in their workflow to hover to see if there's a comment. There's nothing that alerts them that there's a comment there. So try to prevent yourself from putting comments within the medication orders and such, because those oftentimes will be missed. Does anyone else have any questions or comments about this one?
Dr. Blackburn, just going back to the previous case, I think Kelly put in a comment saying that this is why checkout is so important. Helping out the house officer, you know, updating the list to let you know, like, if this person has a fever, they need to start get blood cultures, antibiotics. So it's not kind of, it makes you understand like how quick things need to happen, especially with our sickle cell patients. This patient was actually on antibiotics, so that was good, but the blood cultures hadn't been obtained because he wasn't febrile. So just putting on the checkout, so when you look at that patient, you already know, like, oh, this kid has a fever. Oh gosh, we need to get blood cultures ASAP. So that can get the ball rolling.
Exactly. And I know we've talked about iPass until we're kind of blue in the face, but that's why iPass works well with handoffs, is because it promotes those if-then statements, and it also promotes acuity of patients. So you can know who your sickest patients are, and you can have those, if this happens, then this should happen within your checkout process. I think there was another comment, nursing can only check their computers about every 3 hours, so quick changes should be discussed. And that is true. Our nurses are busy, and so they don't always see new orders. That's why we have you call if you put stat orders in, but definitely if you wanted something changed quickly, you need to communicate in person with them, or at least over the phone with them, so they're aware of changes that are coming with their patients.
And then Dr. Blackburn, I had one thing to say. So also when you're on overnight, if you do have a floater with you, you can also like ask them for help. So if you can't find the senior that is there with you that night, the floater is also there for you as well. We're not, you know, just HEMONC, or, you know, we're all a team. So if you need help, ask them too.
That's a great point, Nisi. So remember, you are not alone in the hospital. If your senior is busy, you have someone floating with you. You also have someone in the PICU. You have someone in the NICU. So don't ever feel like if your senior is tied up or busy that you're on your own. And you have your attending available to you. So all those people are there as your backup for when you feel like you need questions or a second pair of eyes on something. Any other questions or comments? All right, this last slide I just have, and people, if you're on the phone, pipe in if you have updates to your project. I tried to get with Dr. Staples and make sure we had our inpatient projects that were represented on here. Our outpatient ones are usually talked about at our Track 2I meeting. So I wanted the inpatient projects to have an opportunity to mention if they just wanted to introduce their project or if they wanted to give any updates. So Rachel, I think I have you on the spot first. If you have any updates to your project, feel free to give those out now.
Hey everyone, yeah, so I have redone my data collection for this and we got some good information. Basically starting block 5, I'll be coming around and just kind of showing you guys kind of what our thought process is. Really our goal is to help improve actual documentation and diagnosis of our patients who are overweight and obese because obviously obesity is having a big impact on a bunch of comorbid conditions. So that's going to be our focus, and you'll be seeing me a lot in the wardroom, blocks 5 and 6 specifically. I think that's it, finishing up my stuff to do that. So yeah.
Great. All right, Nisi, do you have any updates to your project?
No, I just have to touch base with Dr. Winning, but no updates.
Okay. What about Jeremiah or Jessica? Are y'all on the call today?
Yeah. So we're doing the resident simulations. I think that y'all have been participating in them on wards. We should be sending out some surveys, basically kind of to follow up the 3-month retention of everything that you learned in the first one for those people who are on wards block 1. So be on the lookout for that, and please fill it out. I think that's kind of the only big thing for us right now.
Great. Bethany, are you on the line today? I don't think she's on the line. I don't have any updates to her project. I'm not sure who her advisor is, but more to come on that one. What about Gabrielle? Do you have any updates to yours?
Gabrielle actually had to step out.
Oh, okay.
She may be back in a bit.
Okay. So I know she was working with the PQ1 code curriculum, I think with Dr. Ricker. So we'll hear about hers maybe next time. Megan, do you have any updates to your project?
Yeah, so I had been working on early mobility, but I started a different project with Dr. Ricker on antibiotic administration and antibiotic administration time. So I'm in the process of getting data on that. And then once we kind of get all the data, I'll talk to you all about different steps we can take for PDSA cycles and how we can improve those administration times from the times that we order antibiotics to when they're actually given to patients.
Perfect. And Jaya or Emma, do you have any updates to your project?
Yeah, so we have completed our first PDSA cycle and are in the process of getting ready to do our second, and actually the access of ports, mostly in the HEMONC patients. I know we do have some patients that have ports that aren't HEMONC patients, but accessing the ports properly in the PDD, because a lot of the nurses down there don't access them very regularly. And when we did our initial evaluation, I think like maybe 2 of them out of like 20 actually got everything. We have 2 different interventions. We have a PowerPoint and a video, and we're seeing which one is more effective.
Perfect. So those sound like some great projects that we all can make sure we keep our eyes out for and participate in when they need our help. And I think that's all I have for you guys today. If you have any questions or comments or anything else you want to add, feel free to in the last few minutes.
Guys, hopefully you guys appreciated all the work that's gone into this, because I know you guys put a lot of work into the all hands-on reporting and how important serious safety stuff is, just following up from our talk on Friday. I just wanted to give you guys a couple of real quick updates, because one thing just came across my desk. So the in-training exam scores just came in. please do not rush over here to get them. I got to look through them real fast first to try to make some heads and tails of stuff. But in the next week or so, we'll plan on getting that stuff to you guys so you can look at it. As a program, we did better this year comparatively to last year, which is good. Everything seems to look good from that standpoint, at least on initial glance. And then the other thing, just to remind everybody is, or to tell everybody in case you haven't had a chance to see it yet, is for those of you that were planning on attending Bethany's Journal Club tomorrow, she's got a little bit of laryngitis and problems with cough. So we're going to reschedule that for right now, just because didn't think it was quite fair to her to make her talk for like an hour if her throat's bothering her and she's coughing a lung up, and also to not have to expose you guys to it. So just stay tuned. We'll reschedule that for the near future, but it won't be tomorrow night for anybody that was planning on attending. Okay. But give me a week and I'll get you guys your in-training scores, and we'll talk more about it in some time to come.
Great, and if there's nothing further, then we will let you go a few minutes early. Y'all have a good rest of your Monday.